Yeah, thanks a lot for the invitation today. And yeah, I'm happy to talk to you on behalf of the Harmony Alliance. So I'm Lars Bullinger. I'm a hematologist-oncologist by training, and I'm also the director of the Department of Hematology-Oncology at the Charité in Berlin. And for Harmony, I'm coordinating one of the work packages. And I'm happy to share our project with you today. Next slide. I want to start with some numbers. So Harmony is a real big alliance. It's a community now of over 400 professionals with over 100 organizations from 18 countries. The target is all types of blood cancer, and the initial plan was to build up a platform that contains at least 70,000 data sets. As we knew from previous genomic studies, for example, that we knew that we would need at least 10,000 data sets per disease to start to capture the heterogeneity which we can see in these cancers. Next slide. So we started with the Harmony project in 2017. Like the other IMI projects, it's a private-public partnership which was focusing on collecting big data on 7 hematologic malignancies, which you can see on the lower left panel. The budget was 40 million. That's 20 million coming from the EU and 20 million in-kind contribution from the industry partners. We started with 53 partners coming from these 18 European countries. And as you have seen on the previous slide, today we have over 50 additional associated members. So in total, we already have over 100 partners, and we cover almost entire Europe. Then next slide, we were also successful in asking for some additional money from the EU to come up with a sustainability project, which we called Harmony Plus, which is now also including hematologic malignancies that were not covered by the initial project. We got some additional money to cover these, and yeah, there we are also in the process of collecting the data already. But today I'm mainly going to share some of the first results from Harmony. Next slide. So as I had mentioned, Harmony is a huge project, and it includes all stakeholders that are involved in treating patients with hematologic malignancy. So this is on one hand side physicians, doctors, and academic partners, but also the industry partners. But in addition, of course, also payers, health technology assessment companies, regulators, policymakers, and most importantly, in all the processes, we also involve patient advocates who contributed also significantly to the success of Harmony. And the idea of Harmony was to build up this huge platform where we would have harmonized data in there, and to also come up with outcome measures that should be captured by all the future clinical trials, with the idea to speed up the development of drugs, the bench to bedside process, and thereby increase the use of the omics data that is out there, and use that data to speed up drug development and to put the data into clinical practice. Next slide, you can see here that we so far were successful in a way that we have now already put together over 70,000 data sets already before the end of Harmony. So we reached our goal here, and you can see that many European countries participated effectively in contributing data sets. Next slide. And with regard to the different diseases, we started with AML. That was the first pilot project, and then we embarked on multiple myeloma, acute lymphocytic leukemia, and MDS. So you see that we are moving or have fulfilled our goals for those diseases already, and we are also doing quite well for the other diseases that started a little later. Next slide, I will now also show the architecture of Harmony a little bit. So in contrast to what you heard from Mats, we have a different approach here. We have a central data place, a Harmony Big Data platform that has some disadvantages, as Mats already pointed out, but on the other hand, that allows us to much better harmonize the data to put them in a common data model using the OMOP strategy, and to better quality control the data, and to really harmonize the data sets, that we could do these cross-trial analyses, cross-disease analyses, and have the opportunity to eliminate the bias. On the other hand, the platform was stored in a way, built in a way that it fulfills all the European data protection rules. The data sets that are in there are what we call de facto anonymized. In that way, no individual whose data set is in the platform is put at risk. Researchers who want to use the platform can also only work on the platform. So that means we do not really share the data in a way that it can be retrieved again from the platform, but people who are part of Harmony can work on the platform, but the data stays in that secure environment. Next slide. So now I want to share some of the results, as I think the goal was today also to demonstrate what these huge databases can really do. And here I want to share the data for the AML Pilot Study, where the idea was to look at gene-gene interactions and how they influence outcome. For those of you who are not too familiar with cancers happen that genes acquire mutations when we age, and some of these age mutations lead to the transformation of the cells. They provide the cells with a growth benefit. The cells cannot differentiate anymore. The combination of them gives you cancer. And what we have learned in the past that it matters which mutation comes first and which additional mutations are present in tumors. So for this pilot, we have now put together over 7,000 data sets, which are the basis of the first analyses, and we are currently putting the additional 10,000 data sets that are coming into our validation cohort, based on which we are now then also going to validate our initial findings. And in the next slides, I will give you a slight idea of what the database can do. So with regard to the data granularity, the data that is present in Harmony, we have all types of data collected. We have demographic data on the diagnosis of the disease, but then also detailed information on the treatment of the patients, and then of course omics data, which means with regard to the genomic, the basis of these tumors. Next slide. We then can use the data to, for example, calculate virtual time axis, how the mutations might have occurred, and thereby we can get a glimpse of the biological evolution of these tumors. Next slide, we can use the platform to get further insights into these gene-gene interactions. This is a gene-gene interaction map where you can see that some of the mutations do co-occur, which are color-coded in blue, whereas others are mutually exclusive. And with regard to, for example, response to chemotherapy, or whether we should move forward with patients to transplantation, this is an important prognostic, or those markers can be of important prognostic relevance. Next slide. We then also use the data to correlate it with the clinical information, and perhaps here you can start the video. This is a nice example showing you how big data really matter. On the x-axis here, so you can start the video, please. I will continue to talk. On the x-axis, we have plotted the number of cases. So currently you see the results for something a little bit more than 500 cases. So this is 547 cases. And if you look at the genes such as CEBP alpha, then it's color-coded in green. You can see that this has a good prognostic impact, whereas ASXL1 is a prognostic poor marker labeled in red. But the question, what is wrong with some other markers, you cannot really address with 500 cases. Only in 500 cases is already a quite large study for cancer purposes. But the groups then are often not large enough that you can do these subgroup analyses with a meaningful statistical power. And what is now happening when we increase the number of cases. On the y-axis, I should say, we have plotted the p-values for the prognostic impact of the respective gene-gene interaction. And if you now increase the size of the analysis, and I hope this is now happening, then you can see how the entire picture is changing. So 500, as I said in the old days, is a quite large study for cancer. The first large cancer genome atlas project on acute myeloid leukemia, for example, had only 200 cases. All the other cases, the studies are usually smaller, but here you can nicely see, if you increase the number to 1,700 cases, that many of the subgroups change quite dramatically. And if you go over 2,000, over 3,000 cases, the picture is a completely different one to when you study only 500 cases. And then suddenly you can find markers as poor prognostic markers, which you previously, for example, would have missed. And this is definitely of great importance in the management of our patients, especially, for example, in decision-making with regard to allogeneic transplant or bone marrow transplantation concepts. Now we can move on to the next slide. There's just more details on the gene-gene interactions. Then this is data which we had presented recently at the annual meeting of the American Society of Hematology Oncology. You can click again. We also have implemented tools where researchers can mine the data themselves. They can zoom into these gene-gene interactions. And here you have, for example, another example, and the RAS mutations in AML is responding well to chemotherapy, but depending on the co-occurring mutations, the colors change. That means that the good prognostic impact can switch into a poor prognostic one. And if we understand this better, we can much better target the therapy in our patients and move forward with individualized treatment concepts. Next slide, and then I'm almost at the end. We also use these data sets to study the impact of age, for example, as shown here. These peaks indicate that the biology is switching, that older patients present with a different disease, which in part explains again why we are doing so poorly in treating older patients. It's not only that we cannot as expressively treat them, but it's that they have a different disease. On the next slide, you can see that we also have tools that can be used to study the outcome in our patients. That means survival curves, which are also important for individualizing treatment strategies in our patients. And on the next slide, you can see that in addition to this AML project, we have many more interesting projects ongoing, and not only focusing on AML, but all the other hematologic malignancies. And recently the myeloma project was presented at ASH. It also came up with a new risk stratification for this disease group. Next slide. And with this, I'm at the end. This is the Harmony group at our last personalized meeting, if you wish, in Florence. And I hope that we all can meet again in presence in the future. And I'm happy to take your questions.